This video is going to offer an overview of the anatomy of the respiratory system. Obviously, as I go through these videos, if there's any that you have additional questions on, these individual videos go into each topic in greater detail. So please feel free to make use of those. And so as we begin with the respiratory system, certainly in this analysis, we'll look at how we get air in and out of the lungs. That's what's called pulmonary ventilation. But there is more, and so the next videos will then talk about the external respiration, which is the gas exchange which occurs between the air in the lungs and the blood in the pulmonary capillaries. And then the internal respiration, which is the gas exchange which occurs between systemic capillaries in the tissues. And then a later chapter then talks about cellular respiration. You know, how do individual cells use these gases in order to get energy from our food? So the respiratory system, it's a smaller system, especially for students who are used to the large systems of anatomy and physiology one, all of the bones and muscles and parts of the brain, etc. I know that air obviously can come in and out of the mouth, but for simplicity's sake, I'm just going to talk about the nose and the nasal cavity and leave the oral cavity for a discussion with the digestive system. And so air can come in this external nostril, which is known as the external nares, into this nasal cavity. Now, one of the first things that happens is that the air starts to swirl, because we will see that the tissue which makes up our air sacs in our lungs is simple squamous epithelia, the most delicate tissue in the human body. And when we bring in air, there's germs, there's dust, there's diesel particles, there's sand, so there's these foreign materials. Also, these cells are warm and moist. The air that we're breathing in could be cold and dry. So in other words, this air may not be what we want to introduce into the most delicate cells of our body. And so for the first thing that happens is that there are these three plates which stick out in the nasal cavity known as conchae. Two of them are from the ethmoid bone, the superior and middle conchae, but the third, the inferior nasal concha or turbinate, is its own separate bone of the face. And when we inhale, this air then hits these conchae and starts to swirl. This then moistens the air, it warms the air if it's cold, and if there's any foreign material, it can get stuck in the mucus which lines the nasal cavity, and cilia, which we'll talk about in a little bit, will then move this towards the mouth. Also, while this mucus is dissolving things in the air, some of these are odorants that we might like to know about. Do we smell smoke? Do we smell food? And so we have an olfactory epithelium where olfactory nerves will then transmit the information from what we've just smelled through the cribriform plate of the ethmoid bone. And then, as we can maybe touch on again with the reproductive system, most land-living vertebrates have two senses of smell. In addition to the main olfactory system, they have a vomeronasal system. So there are holes in the vomer leading to a tiny olfactory structure which detects different smells and has its own cranial nerve going to the brain. In the higher primates, including ourselves, this is broken. It doesn't work. And as a result, we don't get the same information from pheromones that most mammals do. So when you look at many mammals, say two dogs, when they greet each other, they're getting a lot of information through smell. We do that much less. And one of the reasons is that one of our two senses of smell, this vomeronasal organ, is non-functional, but it is here in the nasal cavity. Now, it is to be stressed that we do have a nasal cavity, which is separate from the oral cavity, because most vertebrates don't. That's because our maxillary and palatine bones fuse to form a hard palate, and then there's a mucous membrane forming a soft palate from that. And so we can have food in our mouths and still be breathing air in and out, because this nasal cavity is separated from the oral cavity. Unlike say fish, where the nasal cavity doesn't go anywhere, it's just for smell. And there are two nostrils, say, on the side of the face. So, and water with odorants will come in one nostril and then leave the other. Our lineage has moved the internal nostril or internal nares so that it empties into the pharynx. And so that when we inhale air, it's not just for smell, it can then be used to bring oxygen to our lungs. And so once again, I repeat this in a couple of videos. So our nasal cavity has these plates known as conchae, and thus air starts to swirl around, it warms, it moistens, foreign particles can get caught in mucus. Here is that hard palate and soft palate separating the nasal cavity from the oral cavity. And then while this is the external nostril or external nares, here is that internal nares, which introduces the air and allows it to proceed into the pharynx. I have a video, just in case you were curious, which just talks about how ancestral Sarcopterygian fish moved that second nostril. So while it was originally on the side of the face and exterior, it moved briefly to the roof of, I'm sorry, with the tooth margin, and then it moved to the roof of the mouth where it became the internal nares, which could then be functional in bringing air into internal bags, which could then be used for breathing. And then once again, this can be stressed later, because mammals are so expensive. We have a 100-degree body all of the time. Then we have big brains, we walk upright. We need to breathe much more oxygen than cold-blooded, amphibians and reptiles. And we certainly need to be eating a lot more. So if you look at the internal nares, say, of the frog, notice that they empty into the same space as the oral cavity. So even though there's separate holes on the outside for nostrils and a mouth on a frog, they empty into the same space. The same thing would be true of a turtle. But once again, because it is so important that we then eat a great deal and breathe a great deal, the maxillary and palatine bones have fused together to make these separate spaces. So these cows, which have to chew all day, can still be breathing at the same time. And so once again, we have a nasal cavity separate from an oral cavity. And once again, that's unusual for vertebrates. Most vertebrates don't. And so that is certainly, noteworthy. As embryos, the pharynx is a fascinating region. We develop large arches with cartilage bars, slits between them. There's a dorsal aorta, which, sends branches to each of these arches. And then this area gets reorganized. So for all vertebrates, the pharynx is very important. Obviously for fish, this is the site where gills develop. But as adults, our pharynx, there just isn't as much to say about it. So behind the nasal cavity, there is a nasopharynx. Behind the oral cavity, there is an oropharynx. Above the larynx, there is a laryngopharynx. And together, these three areas compose the pharynx. Because these are portals of entry, germs can obviously enter in our mouth and in our nasal cavity. We have 5 masses of tissue strategically located here. So there is a pair of lingual tonsils in the tongue. There is a pair of palatine tonsils in the soft palate. And then there is one single adenoid or pharyngeal tonsil in the back of the nasopharynx. And once again, as such, they can monitor populations of bacteria, given that so many can enter through the mouth or nose. Unfortunately, a chronic inflammation, especially in a child, might cause this to swell, where one of these might interfere with swallowing, with speech, or even with breathing. And so it might come that these are recommended for removal just because chronic inflammation is interfering with other with other important processes. The nasopharynx also has an opening, which is the opening to the pharyngotympanic tube. If you recall from your studies of the ear, that we have an eardrum which has air on either side. There's obviously air in the outside world, but there is also then air in the middle ear. And we need this air to be at the same pressure. Otherwise, if there's more pressure pushing on one side of the eardrum than the other, that would interfere with its vibration, and then we would not be able to hear well at certain altitudes or in rainy days versus sunny days, et cetera. So we need to make sure that this air has the same pressure as the air of the outside world, even if we're going up steps or an elevator or in a plane, or if the weather is changing, et cetera. And so therefore we have this pharyngotympanic tube, which goes to our throat. And so therefore, not only if, say, we go up in an elevator, does the new air with the new pressure, is it here, but also it comes here, and thus this air can be at the same pressure on either side of the tympan. And then the next structure in the respiratory system is the larynx. As I had said, when we were embryos, we had these big pharyngeal arches with bars of cartilage homologous to the bars that fish will use for the pharynx, I'm sorry, the cartilage of their gill arches. And then these then fuse to make a solid structure of multiple cartilage known as the larynx. One of the cartilages of the larynx is the epiglottis, and it is critical because air has a specific passage. It goes from the nasal cavity to the nasopharynx, oropharynx, laryngopharynx. Food has a specific pathway. It goes from the oral cavity to the oropharynx to the laryngopharynx and then to the esophagus. And thus note that the pathway is shared. So food and air share part of a pathway. Not only that, they actually crisscross. So here, the respiratory passageway is posterior and digestive is anterior, but here it switches so that the respiratory is anterior and the digestive is posterior. And the problem is if swallowed food were to become lodged in the airway, we could suffocate. So every time we swallow food, it is potentially lethal. And to protect us, we have this elastic cartilage. We don't have much elastic cartilage in our bodies. We have it in our external ear, and we also then have it here in the epiglottis. And part of the swallowing reflex then is that when we swallow a bolus of food, the epiglottis closes over the glottis so that going into the larynx and trachea is simply not an option for ingested food. It is directed into the esophagus. And so the cartilage known as the epiglottis is vital to prevent us, from having food go in the wrong passageway and thus become lodged in our airway. So there are a number of cartilages which fuse. There is the large thyroid cartilage, which includes the laryngeal prominence, which protrudes a bit more in males because of the action of testosterone during puberty. There is the cricoid cartilage, and the space between the thyroid cartilage and the cricoid cartilage could be the site where a stoma, an opening, is put so that someone can breathe if they have an airway obstruction or following surgery, et cetera. So there's a number of separate cartilages here. Here's the hyoid bone, which we'll get back to in a second. These cartilages are interesting, the arytenoid cartilages, because on one side, they attach to muscles. And then on the other side, they attach to mucous membrane folds known as vocal cords. And so thus, when muscles pull on those arytenoid cartilages, they pull these mucous membrane folds. Air doesn't have to make sound when it flows through a passage. So for example, that was all the air in my lungs and it didn't make any sound. But if I do this, that makes sound. And the reason is because the only way that the air could pass is if it caused that paper to vibrate. And the vibrations in air molecules then cause our eardrum to vibrate, which we then perceive as sound. And so if we can cause something to vibrate as air passes, this will make sound. So we pull on these arytenoid cartilages, which then pull on these vocal cords. And this then causes the folds to vibrate and thus make sound. So this is how we make sound. Volume of sound, say a soft sound versus a loud sound, is controlled by how much air passes. If we force a little air past the vocal cords, that makes a soft sound. A lot of air going past the vocal cords, that makes a loud sound. And so that's how we determine volume. The way that we determine pitch is by how much tension we put on these vocal cords. And so if you're familiar with musical instruments, there are many musical instruments, say like a piano or a guitar, where if you tighten the string, the pitch goes up. If you loosen the string, the pitch goes down. If you can compare the strings which make the high notes versus the low notes, the high notes, they are narrow and taut, whereas the strings that make the low notes, they are loose and very often longer. And vocal cords operate in the same way. If I just use lower pitch sound, I'm going to add the sound for a little bit. All right, so that's a high pitch sound. That's lower. And then lower, all of these are the note of C. But there are different pitches, and you could sing along. But to sing along, you would then be altering the tension here in the muscles which attach to the arytenoid cartilages, which then alter the tension in the vocal cords. When you're hitting a high note, your vocal cords are tauter. When you're hitting a low note, your vocal cords are looser. During puberty, the action of androgens cause the vocal cords in adolescent males to become thicker and longer. And just as you would see in a piano or a guitar, where the thicker, longer strings would make lower sounds, thus in most males, the average pitch of the voice will then decrease as a result. The hyoid bone was evident in that last video. It doesn't attach to any other bone in the body. It is anchored by ligaments from the styloid process of the temporal bone, and then some tongue muscles can then anchor here. So just as different cartilages from those pharyngeal arches fuse to make a larynx, so too they can fuse and then ossify and become the hyoid bone. Now, just one last thought is I very often ask my classes, think of animals which aren't human, and then obviously then consider human anatomy, and then ask the question, what makes us different? Why are we different from the non-human? Certainly there are differences, and my students, I'm sure, come up with a mental list. And then I ask them, do you think of how far your face protrudes or the height of your hyoid bone? And that typically is not on the list. But then I would argue, but it should be, because that makes us different from other animals. And that's actually one of the most important differences. Because when you take, say, for example, a chimpanzee, they are capable of learning limited degrees of sign language with limited degrees of grammar, et cetera, but they can't talk, and they can't talk because this area just doesn't have the right shape. And our ancestors did two things which you'd think, well, not the best choices. They raised the hyoid bone, all right? That's not necessarily the best choice because now it means you're more likely to choke on your food. And the face then got flatter, but it kept the same number of teeth. That's a problem. So in my mouth, there are 8 fewer teeth than there should be. All right, I'm missing 4 wisdom teeth and 4 premolars. And I had braces for 3 years and a retainer for many other years. And I'm sure some of you have similar stories. And so raising the hyoid bone and flattening the face, it means we choke more and we, need orthodontists. But it changed the shape of, the part of the respiratory system which is making sound. And this then allowed human speech, primates very closely related to us, which have a different shape here, they can't speak, even though they can perform sign language. So even though most people don't list, changes in this region as being, critical that separate us from non-human animals, without it, which we wouldn't have speech. And speech is obviously one of the really critical things for humans, and human society would obviously be quite different without it. Now, now that we've made these sounds, we separate sounds into vowel sounds if it is movements of the pharynx which control them. So when you make sounds like ah, eh, or even nasal vowel sounds like you're primarily moving the pharynx. You don't have to move your mouth much. Meanwhile, consonants are things like a B or a T or an S, where we're moving our mouth, lips, and tongue. And so, so that was a bit on sound production, which is obviously important in humans. So from the nasal cavity, air passes into the pharynx, which passes through the larynx, which then enters the trachea. And the trachea then is lined by cilia, just as the nasal cavity is. Now, this is a one-celled organism with cilia, but that's what cilia looks like. And the cilia in your respiratory tract looks about the same. We have goblet cells, which make mucus. This mucus traps microbes, debris, diesel particles, etc. And then the cilia, which we find on the cells lining the trachea, this then sweeps the mucus with all of the gunk which has been trapped in it into the throat, where we can swallow it to the stomach. Now, we call this epithelia pseudostratified. It looks like there are many layers of cells here, and there's not. There's only one. It's just that all of the cells, they don't begin at the same, they don't begin at the same point. Now, we swallow food, my fault. Once we collect this mucus that has, debris and germs, et cetera, in it, we move it to the back of our throats, and then we swallow it into our stomachs. The reason that we do this is because our lung tissue is the most delicate tissue in our bodies. And we certainly don't want to bring germs and foreign material there. So even if swallowing mucus full of gunk is not, the most, pleasing of thoughts, it's far better than bringing it into the delicate tissue of the lungs, because the stomach is a big bag of acid where this, material can be degraded. Now, I had said that we have mucus lining the nasal cavity, mucus lining the throat, and that's because of the presence of goblet cells. Now, most of the exocrine cell glands, which secrete products from the body, do so through a tube or a duct. That doesn't apply to the one-celled exocrine cell. So even though certain things like sweat glands or digestive glands have many cells and ducts, along, say, the trachea, we have these goblet cells which make mucin, and they are a single-celled structures. Although, so here you can see goblet cells of the digestive tract, and they've been stained. But in the respiratory tract, they would look the same. And so these are exocrine glands, but they are one-celled exocrine glands, so they are exceptions to the rules, and they don't have ducts. Air passes through the trachea, the single tube lined by C-shaped rings of cartilage. So in the throat, there are two separate openings. There's the esophagus, the food tube, and then there is the trachea. And under the microscope, one can identify the trachea because of this C-shaped ring of cartilage, which then keeps it open. The trachea divides here in an area called the carina. This is an irritable area. Many times when we cough, coughs are initiated here. The trachea divides into two primary bronchi. One bronchus enters each of the two lungs, and then the primary bronchi break into secondary bronchi. The secondary bronchi are the structures which enter each lobe of the lung. As I'll explain in a second, there are two lobes of the left lung, three lobes of the right lung. The secondary bronchi then form tertiary bronchi, which then continue to divide and divide, forming a series of bronchioles, and then the bronchioles will then end in air sacs, also known as alveoli. And so this is how oxygen will enter the body, going through these, and then carbon dioxide leaves going in the opposite direction, starting in the alveoli, then going into the bronchioles, etc. Obviously, a lot of blood vessels are following these respiratory passageways. This image here was taken from stained lungs of a cat. So these are the blood vessels which accompany the respiratory passageways in the lungs of a cat. And notice how dense they are. Just a reminder that while the left ventricle in humans pumps 70 milliliters of blood to all systems of the body, every heartbeat, 70 milliliters of blood leave the left ventricle, and this goes to the brain, the hand, the digestive system, etc. The right ventricle pumps just as much blood. 70 milliliters of blood is leaving the right ventricle. And from the right ventricle, this blood is going one place and one place only, the lungs. So the lungs get as much blood as the rest of the body combined. While the cartilage of the trachea helps to keep it open, and the cartilage of the bronchi help to keep them open. Once we get into the bronchioles, then there is only smooth muscle. Now, this smooth muscle does contract and relax, just as with blood vessels. We saw that there was vasoconstriction and vasodilation. Here, too, in the lungs, we see that there is bronchoconstriction. So the smooth muscle can constrict, and this will make the lumen of the air passage smaller. And then in the same way, we can have bronchodilation, which would then expand the respiratory passageway. The bronchioles in asthmatics have been chronically inflamed and then can remodel themselves. And the problem with this is now that in bronchioles, we do not have the cartilage, which helps to maintain that these stay open. Thus, when bronchoconstriction is performed, then this can completely shut off an airway, obviously, then making it difficult to breathe. And I have a playlist on asthma, which will continue this further. Now, those later passageways, this is what was occurring in the lungs. And just as we saw that there was a pericardium, a serous membrane around the heart, which then allowed the heart to move. So the pericardium had an outer parietal layer, an inner visceral layer, and a space between them, a pericardial cavity with a lubricating pericardial fluid. We see the same thing in the lungs, but here it is known as pleura. And so there is a pleural membrane around the lungs. So here in yellow, this is lined by a parietal pleura. The surface of the lungs themselves, this is known as the visceral pleura. And between the two is a pleural cavity with a lubricating pleural fluid. Here in the upper right, you can see these are cat's lungs. And here I'm blowing air in and out of the cat's lungs. And you can see that in normal respiration, they need to expand and contract. And I'm sorry that Zoom and the video aren't cooperating as well, but in the video, if you were to just play that by yourself, you would be able to see the lungs expand and contract. So the lung lobes are constantly moving. We don't want them to develop blisters and adhesions. And so therefore, this lubricating fluid in this space helps to prevent that. Now, the lungs, as we will see, is made of air sacs. And to have the air sacs inflated, we need this space here, the space between the pleura, then to have what's called a negative pressure, a pressure which is slightly less than that of atmospheric air. And thus the air sac, think of it as a balloon, which would otherwise collapse, will then be maintained in a more globular, open setting. That is why if the chest cavity were punctured, that atmospheric air being introduced into that pleural cavity would then cause a lung to collapse because we can't have normal air with normal air pressure in that space. Instead, we need negative pressure, which is slightly less than the surrounding air. Just now that we're on the lungs, just a little anatomy. First off, there are things which enter and leave the lungs. So the primary bronchi enter the lungs, as do pulmonary arteries here in blue. That would be a primary bronchus, pulmonary arteries. Pulmonary veins leave the lungs. There are nerves, there are lymphatic structures. But it is interesting then that all of these structures enter and leave at the same place. So the lung on its medial side has what's known as a hilus region. Everything that enters and leaves the lungs enters in the same region known as the hilus. You don't have a pulmonary artery coming in, in one area, pulmonary vein, coming in elsewhere. The lungs are roughly triangular in shape. And so we can use words which we often use for triangles. So we can say that, this bottom part, that is the base. Here we have the apex. There are fissures in the lungs which break them into lobes. Notice that the left lung only has one fissure, an oblique fissure, but that the right lung not only has an oblique fissure, but also a horizontal fissure. And for this reason, the left lung can be split into superior and inferior lobes, while the right lung is split into superior, middle, and inferior lobes. Also, because 2/3 of the heart angles to the left of the midline, there is a cardiac notch, a space in the left lung where it makes room to accommodate the heart. In my video on asthma, my playlist, I go through the tissues of the bronchi and the bronchioles to greater degree. So here are the videos here. I'll just summarize them, but I go into more detail elsewhere. Once again, what defines the bronchi is that we have cartilage which will maintain these bronchi open even when we're changing the amount of air which is passing. So for example, during an emergency, we dilate our respiratory passageways. At rest, we constrict our respiratory passageways. And then here you can see some of the cartilage, which would then be in bronchi. So here's a bronchus, and there's some cartilage helping to keep it open. Notice that we still have ciliated epithelia at the outset, although this will begin to diminish as we go further. And so the cilia of, say, the pharynx are sweeping mucus down towards the throat. In the trachea and the bronchi, we sweep them away from the air sacs. And so once again, here's just, you can see the ciliated epithelia, even in the bronchi, and then also you can see the patches of cartilage. As we proceed further into the bronchioles, that cartilage then disappears. As do the ciliated epithelia. And so bronchioles then, I apologize, before I get back to the bronchioles, I just wanted to show a microscopic slide of the trachea since I had mentioned. So here in a cat, notice that there are two tubes. There is a trachea and there is an esophagus, two tubes in the throat. In humans, there is a trachea and an esophagus. And under the microscope, you can see that, where the esophagus simply has, connective tissue and muscle in its wall, and it will close. Whereas this C-shaped ring of cartilage in the trachea helps to keep it open. Now it's a C-shaped ring of cartilage, and if you were, in say a dissection, you could actually feel the rings of, cartilage on one side, say of the cat in this example, but not on the other side. This is the trachea, the anterior tube, the esophagus, that would be posterior to that. So you really wouldn't get a good look at the trachea, at the esophagus until the trachea was removed. Okay, so I apologize. Back to the bronchioles. So bronchioles, they have a different type of epithelia. There are exocrine cells. There are some cells which are ciliated. They're cuboidal, unlike the cells we saw earlier. There are neuroendocrine cells. And then there's a significant cell type which seems to be unique to the respiratory system called club cells or Clara cells or bronchial or exocrine cells. As we go from the bronchi through the various types of bronchioles to the alveoli, their number increase. They are not ciliated. Notice they have, this club shape. They are important, and they are producing proteins for the bronchiolar fluid, and so bronchioles have this distinctive cell type. So the bronchioles break into branches, and they get smaller and smaller until we reach the air sacs. This is the terminal part of the airway, and this is the functional unit of the lung. So each lung has, say, 150 million of these air sacs or alveoli. Now here's the most significant aspect of them. Notice that here we have an air sac. It is lined by simple squamous epithelia. Notice how flat these cells are. So these are thin, flat cells, the most delicate cells which we have in the body. Here we have blood vessels. Blood vessels are also lined by simple squamous epithelia, known as endothelia. So even though blood in this tube and air in this sac do not mix, the two get so close to each other that diffusion can occur, that oxygen from the air sac can go into the blood tube and vice versa. And so here's just a quick image of what the air sacs of the lungs look like. So notice that these alveoli are the functional unit of the lungs, with 150 million of them per lung. And notice the cells which line them. They are simple squamous epithelia. So you see the disc-shaped nucleus. They are so thin that oxygen can diffuse between them. And so here you can see shots of the air sacs in a healthy lung, the alveoli. But then also the respiratory membrane is composed, in addition to these type 1 cells, the simple squamous cells which line the air sacs, Also, blood vessels, such as this one here, is lined by simple squamous epithelia known as endothelia. And so even though blood and air don't mix, because the blood tube, the capillary, is lined by simple squamous epithelium, and because this air sac is lined by simple squamous epithelia, the blood and the air come so close to each other that oxygen from the air sac can diffuse into the blood, and carbon dioxide from the blood tube can diffuse into the air sac. Air sacs also have other types of cells. So they have immune cells, such as dendritic cells, macrophages, lymphocytes can be present. Certain white blood cells shouldn't be present, like eosinophils, but are in asthmatics. So there are, white blood cells which can be present in the lungs. But then finally, if the cells which line the air sac are known as type 1 cells, then there are also then type 2 cells. And they are important for this reason. An air sac must be kept moist because the yellow here represents the type 1 cells. They are alive. Living cells are 2/3 water. So they obviously have to be kept moist. If you just line, these moist cells with dry air, then these cells will dry out and die. And so we have to coat the air sac with fluid so that the type 1 cells don't dry out. The problem then is, since water has a high surface tension, since water molecules are attracted to each other, this would tend to collapse an alveolus. In an adult, this would make it difficult to breathe, but in a child, such as a premature infant, this might make it impossible to breathe. And respiratory distress syndrome is a significant cause of infant mortality. And so air sacs include another type of cell known as a type 2 cell. These type 2 cells release surfactant. This is a mix of proteins in a solution, which doesn't have the same surface tension as water. So this isn't just water which lines the alveolus, thanks to the surfactant made by the type 2 cells, because now the surface tension of the fluid is reduced. This helps to keep the alveolus open. I'm making this video very early in the coronavirus quarantine. And at this point, it seems that these type 2 cells are a major portal of entry, that the receptors that type 2 cell, that coronavirus is binding to are these type 2 cells, that they are significant. So these cells are undoubtedly important for multiple reasons. So this was a quick overview of the anatomy of the respiratory system, except for the respiratory muscles, which will be quickly mentioned in the next video.